So this is my first attempt at trying to record my lectures in PowerPoint. I'm not going to go back and re-record the lectures that I've already done, but I'm going to try and do the ones from here on out for the remainder of the course. For this particular lecture, we are going to be focusing on individual characteristics in health seeking with a primary focus on personality traits and personality disorders and how they impact really all facets of healthcare interactions. And towards the end of the lecture, we're going to spend a little bit of time talking about an area that is the primary focus of my research, which is malingering and factitious disorders. So I'll describe them in a little bit more detail towards the end of the slides. Before I get started talking about the material on this slide, I just want to let you know that I'm going to be following pretty closely to the lecture notes that I've posted on Blackboard. An advantage to the recorded lecture is that I may insert some examples that aren't necessarily located in the lecture notes, or I'll be including examples that will supplement any examples that I've included in the lecture notes. So one thing that I would recommend is to go through the lecture material, the unrecorded lecture first, to just get an overview of what this section talks about, and then to actually go through with the recorded if you can handle the sound of my voice, so maybe you can hear some of the examples that I give. A lot of the information on the next few slides has been examined by individuals that study positive psychology. It is a relatively new emerging field. It has a humanistic kind of impact to it. Humanists are individuals that really focus on the positive traits and states that people elicit that make them well-adjusted individuals. And one of the reasons it's important to go through this to identify positive states is because by finding out what makes a person be healthy of mind and healthy of body, that in turn can help us potentially create treatments for those individuals that have more negative affective states. So as you can see from the slide, there's a lot of research looking at the role of positive states in terms of frequency of illness, acute illness, as well as chronic illnesses, but also in terms of the severity of the symptoms that people experience. So people that score high in positive states, and as the slide defines, a positive state is scoring high in extroversion and showing high scores on measures of positive affect. And positive affect are usually positively valenced emotions: happiness, contentment, being enthusiastic. People that score high on these particular measures are individuals that don't report getting sick as often, so they are far more likely to report being healthier than those that show negative affects, colds, respiratory infections, the flu. But when you consider chronic illnesses, those that are more costly for the country, these are individuals that aren't as likely to suffer from chronic conditions, and if they do suffer from chronic conditions, the severity of the symptoms that they experience are oftentimes much less than those that score higher on measures of negative affect. And that's really important to know what is allowing them to have a better outcome, because ultimately that ends up impacting, our national health care overall. Now, one of the things that's important to note is that just having a positive outlook on something doesn't mean that if you're diagnosed with a certain form of cancer or coronary heart disease, all of a sudden you can heal yourself through positive thinking. That's not something that's really been empirically validated just yet, but what has been empirically validated is that those people that do score higher in positive states, when they do experience a chronic illness, oftentimes they don't experience as severe of symptoms, and the length of the illness is oftentimes far shorter than somebody that scores high on negative affect. So one of the positive states that is frequently examined by researchers is optimism. Now, there are a lot of different definitions of optimism. I've included two of them on the slide here, one of which is just your expectations that more good things are going to happen to you in the future than bad things. I give an example in the lecture notes. You just finished an exam and you found it to be really difficult. Somebody that scores higher on optimism would say, you know what, I studied hard for this, I tried my best, we're going to see what the outcome is, but even if the outcome isn't what I expect it to be, I know what I can do in the future to be successful. Now, many of you know that kind of the opposite of optimism is pessimism. So for a person who's just come out of a test, a pessimist would kind of err on the side of, wow, that exam really sucked. I don't know how I'm going to be able to study for the next test. I just clearly am not going to do well in this class. So you can see how there's quite a different level of thinking that occurs between the two. Optimism can also refer to the person's sense of hope and how they feel they're going to be able to accomplish their goals. So much of what optimism has been related to in terms of health psychology is stuff that I already mentioned in the previous slide. People that score high on levels of optimism have fewer acute illnesses, such as colds and flu. When they do get those acute illnesses, they often report fewer physical symptoms. They're less likely to develop chronic conditions. Interestingly enough, there's research to show that for people that score high on levels of optimism, if they have to be hospitalized or they have to undergo surgery, not even for a chronic condition, just maybe they got in an accident and need to have surgery, these are individuals who have to stay in the hospital far less than a person that scores lower on optimism scales, and they also are less likely to suffer from any sort of complications that would require them to be rehospitalized. Now, one thing to know is that there's a difference between optimism and something called unrealistic optimism. Unrealistic optimism is sometimes referred to as optimistic bias. Here's a way that you can distinguish them from each other. Someone who scores high on optimism would say, okay, so I just got diagnosed with this particular condition. I'm going to think about this in a positive way. I'm going to get through this. Versus somebody who's unrealistically optimistic, that can't happen to me. I'm just a very happy person. It's just never going to happen to me. In the latter example, that's an individual who is more so in denial, almost somewhat naive about what they can potentially be exposed to. And what's been found through research is that people that exhibit high levels of optimistic bias are much more likely to engage in riskier choices because they don't think that they're going to be subjected to any sort of poor outcome from something. One of the other positive personality traits that has been extensively studied in health psychology is the trait of conscientiousness. Some of you may remember that conscientiousness is considered one of the big 5 personality traits. People that score high on conscientiousness typically go into careers that are very driven and goal-oriented. These individuals are described as hardworking, determined, ambitious, whereas people that score low on conscientiousness have a tendency to be labeled as indecisive, lazy, unambitious, disorganized. Within health psychology research, it's been found that there's an inverse relationship between levels of conscientiousness and risk-taking behavior that can impact health. Specifically, those people that score high on conscientiousness have a tendency to engage in more health-promoting behaviors. They exercise more, they eat better. They don't smoke, they don't engage in risky sexual practices. They don't do things that could potentially put them at risk for chronic diseases later on in life. The graph that I have, or the figure that I have on the right-hand side of the slide, was taken from another health psychology textbook, and it just illustrates to you for both men and women that score high on conscientiousness, specifically in the top 25th percentile, they have a tendency to live longer than those individuals that score in the lower quarter of conscientiousness. The next few positive personality traits that we're going to be discussing are locus of control and hardiness. Now, we're going to talk about them in quite a bit more detail in the Section 3 material as it relates to, or as they both relate to stress and our coping responses to stress. So for now, I'm just going to define them for you and give you some examples of them. For those of you interested in seeing where you fall in terms of locus of control and hardiness, I've included some questionnaires that you can answer and score yourself on Blackboard in the lecture activities folder. So in terms of locus of control, it refers to the extent to which a person believes they can control the events that are affecting them in some way. So let's take a health psychology related example. Let's say you come down with the flu. Someone who has an internal locus of control would say that it was their choices that led them to getting sick. Oh, I should have gotten better rest. I should have not allowed myself to get so stressed out. I should have been taking my vitamins. Somebody with an external locus of control feels that there are outside factors, extra personal factors that are influencing them in some way. So using the same example of catching the flu, somebody who leans more towards an external locus of control would say, I really wish that some of my classmates would stay home if they were that sick. Or I really wish that the weather wasn't so crappy. It needs to decide if it's going to be hot or if it's going to be cold, because that's doing nothing for my immune system. So they really don't kind of take any sort of accountability. Using another example as it's listed in the lecture notes, let's say you get a test back and you get a grade that you didn't expect to get. It's much lower than you thought. Somebody who takes more of an internal locus of control would say, okay, well, this stinks, but I probably studied the wrong material, or I didn't put as much time into studying for the test as I should have, so let's try and work on that next time. Someone with an external locus of control would really err on the side of saying the teacher purposely made a very difficult test, or there was an unfair amount of material on topics that we didn't really talk about. Now, this is more, we have tendencies to take internal or external locus of control. It's not like an either or sort of thing, but for it to be a personality trait, people that score high in internal are individuals that really go more towards ascribing certain things as being within their own control versus people that tend towards the sides of external, saying the things are outside of their control. When you hear people say, well, this is just bad luck that I ended up getting cancer, that's really an example of external locus of control. Now, in terms of hardiness, some people equate hardiness to resiliency, and there are a lot of similarities between the two. With hardiness, it's how well or how a person reacts in challenging or stressful situations. Somebody that scores high on hardiness will see things as challenges. They will see it as an obstacle that they feel that they can overcome. They'll make statements such as, this is one setback, but setbacks are just part of the game. Or, I need to see the big picture. This little element right now stinks, but in the grand scheme of things, I'm going to succeed. Somebody that scores low on hardiness is going to see things more as threats. Oh my gosh, I don't know if I'm going to be able to accomplish this. I feel very out of control. I don't know if I'm going to be able to succeed. Now, some of this may sound very familiar to you, and really there's a lot of these things that all go along with each other. Hardiness is tied into self-efficacy, and it's tied into the type of coping responses that people choose. Ultimately, when people have an internal locus of control and high hardiness, that really just equates to better health versus somebody who has an external locus of control and low hardiness. So we didn't spend too much time talking about the positive states, not because they're uninteresting, but just because there's a lot of research looking at negative personality traits and how they relate to health. So we're going to spend the rest of the lecture material talking about those personality traits that are associated with bad health or poor outcomes. The first one that we're going to briefly talk about is neuroticism. Now, this also is one of the big 5 personality traits. Neuroticism is basically the same as negative affect. It's a broad personality dimension that refers to the tendency of some people to experience negative emotions: guilt, distress, anxiety, nervousness, fear. A lot of the types of symptoms that you see related to depression and anxiety. Well, what's been found in terms of health psychology is that people that are high on neuroticism report greater symptoms, a greater number of symptoms that they experience, and along with that, they also experience a greater severity of symptoms. As I'm sure you can imagine, the personality traits that are positive is associated with better health. Personality traits such as neuroticism are associated with worsening of health, greater mortality, higher likelihood of chronic diseases, higher likelihood of prolonged acute disorders or illnesses, poor outcome after hospitalization and surgeries, and so on and so forth. So that's what we're going to be spending a lot of time talking about. One last kind of general negative trait that we are going to talk about that you may have heard of before is the whole idea of a type A versus a type B personality. Again, just like with locus of control and hardiness, I'm not going to spend too much time talking about this because for your next assignment, the stress response analysis, I actually have you take a questionnaire that allows you to assess whether you're a type A, B, or this third type, a type D. So I won't tell you about it now, so you can wait for the next assignment. But you've probably heard of a type A personality as it relates to heart disease and heart attack risk. Type A personalities are very, very driven. They're very driven competitively. Everything has to be a game in all facets of life. You're driving to the restaurant and I'm going to meet you there, well, I'm going to beat you. You're taking this test, well, I'll take it in a shorter amount of time. You were able to make 30 phone calls at work, well, I was able to make 35. So it's really in all aspects of life. These individuals are prone to experiencing anger and especially hostility, and there's always a sense of time urgency with these people. It's not so much that they want to multitask, they almost experience a need to multitask. They have to try and get as much done in as short of a period of time as possible. Type B personalities are pretty much the exact opposite. These are people that are very lax, very cool as a cucumber. They'll take it as it is. They're not rushed. Things will happen when they happen. Well, as you can imagine, there's a significantly higher risk of heart disease and stroke and heart attacks in people that are type A personalities versus type B personalities. This whole concept of a type A versus type B originated in the mid-50s via, surprisingly enough, not psychologists, but cardiologists. They were trying to figure out the different factors that are associated with heart disease risk. And so these two cardiologists, Drs. Friedman and Rosenman, really were studying these risk factors in married couples. Now, although women consumed more cholesterol and they consumed more fat and had a higher fat percentage of their body content compared to men, men were the ones that were much more susceptible to heart disease. And one of the women that was being interviewed suggested that it could have been related to the men's profession, because at that point in time it was still very much tradition for the women to stay at home and take care of things in the domestic setting, and men were to go out and be the breadwinners. Taking from this, they actually listened to the people that they were interviewing. They decided to interview upwards of 3,000 healthy middle-aged men and followed them longitudinally over a period of about 9 to 10 years. And they wanted to see which one of them ended up developing heart disease or heart problems versus those that didn't. And they were looking at all aspects, but what we're focusing on here were the personality traits, which they labeled type A and type B. What they ended up finding was that of about the 250 people that had a heart attack, almost 70% of them would have been described as type A personalities, whereas only about 30% of those 250 people would be described as having type B. Now, without going into statistics, you can imagine that a 70% versus a 30% rate is probably statistically different. So from there was a whole bunch of research that resulted trying to look at what component of a type A personality led to heart disease risk. Now, more recent research over the past 2 or 3 decades has shown that it's not so much the type A personality overall, but really the subcomponent of anger and especially hostility that seems to be the biggest risk factor for heart disease. Now, as you'll see in the Section 3 material, there's been a type D personality that's kind of come out. Why people didn't come up with a type C, I really don't know. But you'll see actually that a type D person has an even worse outcome than a type A person. So now we're actually going to talk about the part of the lecture that some people find really interesting, and that's what some of the supplemental readings are about: personality disorders. Now, I forgot his name. The Sperry chapters relate to the 6 most common personality disorders that are the most problematic when it comes to healthcare settings, but I'm actually going to go through all 10 personality disorders, and I'll describe some of the diagnostic criteria and give you some examples of patients related to some of these specific personality disorders from my own experience during evaluations and then just what I've been exposed to in research. As I've noted on the PowerPoint and noted in the lecture material, you're not going to be responsible for memorizing the specific diagnostic criteria for each of these disorders. Really, I want you to focus on the main review slides. You're going to need to be able to access this lecture material when you complete assignment 3, and you're going to want to familiarize yourself with the differences between these 10. So I'm going to be going through this information in much more detail in this recording than you're going to be required to know for the test, but I feel that providing you with a lot of detail will hopefully make it easier to distinguish them from each other. So just a little bit about personality disorders in general. Why should we even talk about them? Well, just like with psychological states, personality disorders occur in primary care settings about 20 to 30% of the time. That doesn't seem like a very high percentage rate, but if you think about it, that 20 to 30% can end up costing the healthcare industry quite a bit of money. Now, one of the biggest differences between personality disorders and psychological states is that personality disorders are chronic patterns of behavior that you see across multiple contexts. This is ingrained in the person's personality, and as you've learned in other classes, personalities is in part derived by genetics. It's also in part derived by environmental state. A big thing with psychology or psychological states and personality traits, how do you know? Like, it's the chicken or the egg sort of question. How do you know that a person doesn't become depressed or anxious until after they've been diagnosed with something versus was it their pre-existing depression that made them more prone to it? And that's one of the biggest issues with studying psychological states. But with personality, we know that this has been a pattern of behavior for almost the entire life. So it's likely that this person's way of behaving pre-existed before any sort of medical condition. Now, it's not the role of a physician or a physician assistant or a nurse practitioner to diagnose somebody with a personality disorder. As you probably see in the readings, it's noted that if there's any sort of red flag that concerns the physician, they should refer the patient to a psychiatrist. But what they can be part of that multidisciplinary team that helps give information as to whether a person has evidence of a personality disorder or not. So what a psychologist usually does if they do see one of these patients is they first have to rule out, and this can be done with the help of a physician, they have to rule out anything else that could potentially be causing this pattern of behavior that seems to be somewhat abnormal. Are they having some sort of reaction to a significant stressor? It could be that they just didn't react well to a family member dying or to the loss of a job, and this may not be a long-lasting behavioral change that you see. You have to make sure that you distinguish a personality trait that's indicative of a disorder from some sort of psychiatric disorder. Now, in former versions of the DSM, psychiatric disorders were referred to as Axis 1 disorders versus personality disorders, which were referred to as Axis 2 disorders. We don't have the Axis system anymore, but I'm talking about you have to be able to distinguish somebody who is withdrawing from society, if that's more of a cluster A personality disorder, or if that's some sort of depressive episode that they're experiencing. And only a psychologist would be trained enough to be able to distinguish between the two. Are the behaviors that they are exhibiting the result of something physiologically that's going on with their nervous system? Is it early onset dementia? Is there some sort of neurological problem that's causing them to act in the way that they act? In some frontal lobe issues, if a person has a frontal lobe tumor or they've hit their head and they have some sort of frontal lobe damage, some of the behavior that they engage in may actually seem very similar to the type of behavior you would see, for instance, in people with cluster B personality disorders. So you really want to make sure that you're ruling out any sort of medical or neurological issue. You also want to make sure that they're not having some sort of adverse reaction to medication that they may be on, or if their medication needs to be adjusted in some way. And finally, you want to make sure that their behavior that you're observing isn't the result of some sort of substance that they're using, a non-medicinal substance, so recreational drug use or recreational drug dependence. This is kind of an extreme example, but I think an applicable one. There is a condition that occurs in somebody who's a chronic alcohol abuser. It's called Korsakoff syndrome, and it's actually a neurological disorder that a person can develop. And again, a lot of the behaviors that a person exhibits with Korsakoff syndrome, lack of insight, poor judgment, very bad social behavior, could potentially be viewed as a cluster B personality disorder. Now, these don't kind of exist in a vacuum, so oftentimes what complicates the issue even more is that personality disorders oftentimes co-occur with either other personality disorders or psychiatric disorders. For the sake of this lecture material, we're just going to focus on personality disorders by themselves, but always keep in the back of your mind that these oftentimes don't exist by themselves, and that's what makes it even more complicated to interact with these patients. Okay, so for all personality disorders, there are 4 core features, and for those of you that are familiar with the Diagnostic and Statistical Manual of Mental Disorders, the DSM, you actually see these 4 core features in the diagnostic criteria of most of them. So I'll go through each one of them. I'll be following pretty closely with the lecture notes here, but I'm also going to give you some examples as well. So first of all, there are extreme or disordered thinking patterns. People tend to exhibit distortions in the way that they interpret and think about the world, and even how they think about themselves. And oftentimes it's quite different than how a healthy personality would think about things. One type of distorted thinking is the all or none sort of thing. There is never a shade of gray for these individuals. It's always this, it's never that, which can be problematic. There is frequently idealizing individuals or devaluing people. You know, the doctor that you're seeing is either the best doctor in all of the country and you are so lucky to be blessed with this person's presence in time. Or if things aren't going the way that you want them to, that's the worst doctor who should be reported to the medical board, the license should be taken away. So that kind of goes along with the either or feeling as well. And for some people, this idealizing and devaluing can kind of flip a switch very quickly depending on the mood state of the particular person. Oftentimes there's a heightened level of suspiciousness or being distrustful of what other people are thinking or feeling about you, feeling like you're being criticized or being judged. Another type of distorted thinking could be odd beliefs like superstitions or odd religious beliefs or practices. This you oftentimes see quite a bit in the cluster A's, specifically with this schizotypal or schizotypal, depending on how you were taught to pronounce it. There can also be perceptual distortions, again, which is common in people with schizotypal personality disorder. A second core feature is problematic emotional responses. What I like to refer to this as, because that's kind of a mouthful, I like to say that they have emotion regulation problems. They are either too over-controlled, such as what you see with obsessive-compulsive personality disorder, or they are way up and down, and there is no way for you to figure out when they're going to be up or when they're going to be down. A lot of the cluster B personality disorders have significant emotional regulation problems. The third core feature involves impulse control problems. Again, just like with the second feature, I like to call it impulse regulation problems. For some of these personality disorders, they are very controlled, almost to the point of being rigid. OCPD, obsessive compulsive personality disorder, is another example of that again. Or you have individuals that are very prone to impulsivity, picking up, moving across the country, emptying out the bank account, having sex with someone you just met on the street. Again, cluster Bs have some big impulse regulation problems. So for each of them, we'll talk about these. And then significant interpersonal problems. This is the issue for all of the personality disorders, some more so than others, but this is across multiple contexts as well. Interpersonal problems at home, at work, in social settings. So like I said, we're going to talk, as I talk about each of these personality disorders, you'll get a sense as to where they fit along these four core features, and I'll try and give you guys examples whenever I can. So we're first going to start talking about the cluster A personality disorders, which are characterized as being odd or eccentric. There are 3 personality disorders that fit in the cluster A domain: paranoid, over here, schizoid, and then schizotypal. So this is actually a table that I took from the Ward article that you guys are required to read, and I took the next slide from that as well. But I'm going to review through the differences between the 3, and this would be a really good review slide to go through when you're reviewing for the test, just to make sure that you can distinguish them from each other. The paranoid personality disorder is very much as the name implies. These are individuals that are constantly suspicious and don't trust anybody. There was one example of a patient that I was testing very early on in graduate school, so it was a little nerve-wracking. He was a bit of a domineering man, but we would have these little testing rooms, and they didn't have any windows by them, so that was nerve-wracking in and of itself. But right off the bat, when I started testing him, he asked if he could record our testing session, and I tried to say to him very diplomatically, I was like, no, unfortunately, these tests are standardized and they're copywritten, and it would be against test protocol for me to allow you to record this particular situation or testing environment. And he got very defensive. He thought that he accused me of taking his answers and allowing people to look at them that wouldn't be qualified to look at them. He was afraid that we were going to fudge the data so that his workers' compensation company would stop giving him disability payments. At one point in time, he said that he was going to write a book about his experience, and I was going to be the focus of 3 of the chapters in the book because of how horrible he thought I treated him. This was just somebody who was very distrustful and very suspicious about everybody's motives. I have not had an opportunity to interact with anybody who exhibits schizoid or schizoid behavior. Schizoid personality disorder may sometimes be confused, and rightfully so, as the name implies, with negative symptoms of schizophrenia, or somebody who is extremely socially awkward or even very, very depressed. People that have schizoid personality disorder are very detached from social relationships. They do not interact with a whole lot of people. In fact, they don't spend a whole lot of time even with their own family. And they don't seem to have a broad range of reactions. They don't emote very much. It's almost as if these people come off as very robotic. With schizotypal, this is probably what you most associate with some of the positive symptoms of schizophrenia that you learned about in class. These are individuals that are very eccentric. I always like to give an example of one of my favorite all-time movies, Willy Wonka and the Chocolate Factory. Not the Johnny Depp version, even though Johnny Depp is a very, very good actor. I actually like the original one from the late 60s, early 70s. Willy Wonka, though, is a really great example of somebody with schizotypal personality disorder. He's eccentric, he dresses very weird, even the way that he speaks and interacts with other people is not what you would typically see from a normal social interaction. Sometimes these people have odd ways of thinking, odd ways of feeling about things. They may have routines or practices that are superstitious or magical, and we'll talk about how that can actually impact the patient-provider communication style in just a second. Okay, so this is a table that I adapted, as you can see from the bottom of the slide, from Table 5 from the Ward article. These tables for each of the clusters would be really, really great, hint, 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 to review for the exam, because it breaks things down by the specific disorder and then some of the prominent features of those disorders, the types of general experiences that these individuals have during a particular illness, the problematic behaviors that a physician needs to be mindful of, and BXS is just my abbreviation for behaviors. And then the ways in which physicians and nurse and healthcare setting or healthcare professionals can actually try to manage these patients and minimize any sort of difficulties that may arise from interacting with them. Because, as I'm sure you know, the main goal of a healthcare professional is to help treat the patient. And anything that can lead them to that path of success is going to need to be used. So for somebody that has paranoid personality disorder, the biggest thing is to not question them, to be empathetic for their fears, to say to them, I understand this must be very difficult. You've seen a number of doctors and it doesn't seem like you've been getting the answers that you need. And so to really try and help lighten up their feeling of vulnerability, because what you oftentimes see is the more insecure and fearful and lacking of knowledge they are about a particular condition that they have, the more you're going to see those prominent features of distrust and suspicion. So that's kind of one of the first things that you want to do off the bat, is to be very empathetic to their fears. But you also don't want to talk around certain things. You want to be very clear about your explanations. You want to be able to provide them in layman's terms, and you ultimately want to assure them that you're not to be feared, you're not the bad guy, you want to be on their team, and you want to help them get better. Now with the schizoid personality disorder, oftentimes one of kind of the default things that physicians try to do is they try to make some sort of personal connection right off the bat to build rapport between the patient and the doctor. The problem with schizoid personality disorder and that sort of approach is that that's going to set them off, actually, and they'll start to engage in even more detachment and emotional restriction. That's the last thing you want to do, is just to kind of shoot around the bush and be like, hey, how was your weekend? How's the family? Oh, so on and so forth, because it's not that they don't want to be connected to you, they just are very closed off from other people in the world, especially strangers. So it's best to just be very businesslike with these individuals. You don't want to get too familiar with them. You don't want to get too involved in their life. You meet with them, you explain the facts, you give them explanations, you ask them if they have any questions, and then they can be on their way. With schizotypal, it's a little difficult because you have to make sure that you're giving them an opportunity to voice some of their beliefs, which may be very odd. You don't want to necessarily encourage or reinforce those odd beliefs, but you don't want to kind of quash them either. So oftentimes these individuals may delay seeking treatment because they feel some of these superstitions or other odd behaviors that they engage in will help them get better, and it's only until the point when it's not helping them get better that they actually seek treatment. So just like with the first two, you want to adopt a professional stance, be very clear in your explanations, don't get too involved in the person's personal life. Try and tolerate their odd beliefs, but don't endorse or encourage them too much, because we don't want them to engage in any sort of activity that will take away from the more traditional treatments that they should be doing. I don't think I'm going to read through each of the diagnostic criteria for these particular personality disorders. With the case example that I gave you of the man just a few minutes ago, you can probably see and apply some examples from that scenario to the diagnostic criteria. One thing to note with these criteria, it's not that you have to have the presence of every single one of these in order to be diagnosed. For this particular case, for example, you have to have at least 4 or more of the following. Usually it all happens beginning in early adulthood, and it's across multiple contexts. So I'm just going to go through these pretty quickly, and if I think that there is a need for clarification, then I will certainly let you know. So these are just the criteria for schizoid or schizoid, however you'd like to pronounce it. And this one is schizotypal personality disorder. One thing to just clarify for you guys, ideas of reference corresponds to, I'm trying to think of a good example. Let's say somebody was watching a news story. They would actually say, oh, they just did that news story about me. They're referring to my condition. They think that anything that they read or anything that they see on social media or on the television is directly related to them in some way. The next cluster of personality disorders are the cluster B personality disorders, and we actually have 4 within this cluster. This is the only cluster that has 4 personality disorders. Cluster Bs are characterized as dramatic, emotional, or erratic, and to be quite frank, this is one of the clusters that gives physicians and healthcare professionals the hardest time. And I actually do have some very good examples related to some cluster Bs, so hopefully you will enjoy some of the stories I have to tell. So the first one is antisocial. One of my biggest pet peeves, and it's completely irrelevant to this entire lecture, but I just have to get it out there. I don't like when people misuse antisocial. Antisocial is referring to a very specific behavioral pattern. Somebody who lacks empathy, sometimes engages in criminal behavior, doesn't care for the rights of other people, is very manipulative. It does not mean somebody that doesn't like to go out. So you may describe a friend of yours, oh, he or she's just being antisocial. That's actually asocial. Antisocial refers to this very specific type of behavior that you see here on the slide. Borderline personality disorder is characterized by a very marked instability in interpersonal relationships. They also have an insecure self-image and emotional lability, which just means mood swings. And they are also characterized by pretty significant impulsivity. With histrionic personality disorder, and I'm not trying to belittle individuals that have histrionic personality disorder, but these are kind of the actors and actresses that you will see in a healthcare setting. These are individuals that will display excessive emotionality, oftentimes emotions that don't seem to fit the context, and they will engage in attention-seeking behavior oftentimes, which is tied in with the emotionality. With narcissistic personality disorder, these are the people that feel that they are better than others. They experience or display a level of grandiosity, a need to be admired. They also share a commonality with antisocial personality disorder in that they exhibit a lack of empathy. So I'm going to talk about how each of these can impact the treatment relationship. So again, this is a table that's adapted from the Word article that I had you guys read for the class. And again, just like with the cluster A, it breaks it down by disorder, the prominent features of each disorder, the types of experiences they have with their illnesses that physicians may observe, any sort of problematic behaviors, management strategies. I'm going to spend a little bit more time talking about this slide because this is the cluster, like I mentioned, that provides the biggest, conflict and issue in being able to treat. And when I have applicable or relevant examples, I'll try and give them to you. So with antisocial personality disorder, one of the biggest things that you have to be very careful of is the authenticity of their symptom report. Now, a little bit later on in the lecture, I'm going to be discussing with you malingering, which is the intentional fabrication or exaggeration of symptoms for the sake of secondary gain. I'm not saying that people that are malingering are all antisocial, but it has been found that there is a higher level of antisocial behavior in people that are malingering than other personality disorders. So one of the things you have to be very careful of in somebody that has antisocial personality disorder is you want to document everything, and you want to document things as objectively as possible. You want to investigate their concerns, but you also have to kind of take it a step further and investigate the authenticity of their concerns and their symptoms. These individuals may have various motives into going to the doctor. They may be doctor shopping in order to get medication, or they may be doctor shopping because they're trying to get that one doctor who's going to agree that they need surgery or that they can't go back to work. So they may manipulate their report of symptoms in such a way to get what they want. One of the classic features of someone with APD is a lack of empathy and a lack of guilt or remorse. So they won't have any problem with lying about something if it's going to get them what they want. So it's always best to not obviously make it known that you're suspicious of them right off the bat, but you're going to want to try and be as fact-based and objective as possible, so that should they come back and try to accuse you of doing something, you have all of the documentations necessary to prove that you were just trying to treat them. With borderline personality disorder, one of the biggest things that a healthcare professional needs to be mindful of is setting very clear boundaries. Somebody with borderline personality disorder, upon first meeting them, acts as if they've known you their entire lives. You learn of their life story within the first 5 minutes. Oftentimes, you learn information about these individuals that you don't need to know. That's completely irrelevant in your need to treat them. there's a lack of being able to kind of pick up on those social cues because there's such a strong desire to be linked to somebody. And what you have to be careful of as a healthcare professional, and especially if it was an opposite sex healthcare professional, is that you don't want the patient to become too overfamiliar with you, to think that in some way you are friends or you are close to each other in a way beyond just a physician and a patient. So it's very important to set firm limits with these individuals, to set very regular, regimented visits. It may be that if the person starts to feel really, really comfortable with you, they'll try and see you frequently, and they'll start to increase the number of visits that they schedule with you. These individuals have a fear of rejection and abandonment, so you have to be careful in telling them, it's not you I don't want to see all the time. It's just, it's not customary for somebody with your condition for us to see each other more than once or twice a month. The reason you have to be so mindful and be firm but tolerate some of their behavior is these individuals may engage in behaviors that can be self-destructive. So if they feel that they are being rejected in some way or they're not getting the attention that they need, they may overdose on medication, or they may engage in some or other risky behavior that can impact their health in a very negative way. With histrionic personality disorder, and I have a patient example of this one, these are individuals that are very theatrical, very emotional, oftentimes to a much larger extent or magnitude than you would expect given that particular condition. Some individuals that are histrionic are very overdramatic, they're very attention-seeking, and oftentimes they will be very sexual in the way that they interact. So I have two examples of histrionic, one that was somewhat sexual in nature and then one that's just more of the emotional. My apologies for those of you that like the Kardashians, but the Kardashians would probably come pretty close to qualifying as histrionic. So the one patient that I had was an individual whose workers' compensation company basically said she had to go back to work. They did not believe she was as disabled as she was when she first went on disability. They thought she was capable of going back to work, but in order to go back to work, she needed to be evaluated. So I was responsible for evaluating the individual for her pain psychological evaluation, and the way that my former group used to work, the pain psychological evaluations could be finished in a one full day testing period. Sometimes it would be broken up into 2 days. This particular patient was broken up into 11 testing sessions. I would drive to the testing center, I would test her for about 15 minutes, and then it would just be too much for her to take. And so then we would have to discontinue for the day and reschedule. So she only could tolerate very short instances of testing. But what I found very interesting was that everything seemed to be very effortful and very laborious for her. At one point in time, she wanted to take a break so she could use the restroom, and she ended up getting stuck in the restroom because she was too weak to open up the bathroom door. And rather than just knocking on the door, all of a sudden I heard screaming, and she was crying, and when I opened up the bathroom door for her, because she hadn't locked it, she was sitting on the floor crying and praying, and she was just like, I can't handle this anymore. I don't know why you people are doing this to me. And it got to a point where she was actually disrupting the appointments of other patients. So we discontinued for the day, and I rescheduled with her, and she canceled that later appointment because she couldn't get out of bed that particular day. And then she brought in, during our fourth appointment, a letter that she had written expressing just how uncomfortable and emotionally taxing the whole process was. This is somebody who had gotten hurt at work, and there was no question that she had gotten hurt at work, But she had gotten hurt at work 3 years before, and she didn't have, at least there was not evidence from an objective standpoint, evidence of her not being able to go back to work in some sort of capacity besides what she was self-reporting. Now, the other example of histrionic personality disorder involves a woman who was very interesting indeed. She walked into the testing room and was very mindful of her appearance. She was wearing a button-down blouse that was about 2 sizes too small, so it was kind of gapping in between the buttons. She wore a mini skirt with fishnet stockings and 5-inch heels, and she was all dolled up with her makeup and looking as snazzy as could be. And at one point in time, I handed her a writing utensil to fill out some paperwork, and she conveniently dropped the pencil and in a very suggestive sort of way bent over to pick up the pencil. It was all very Marilyn Monroe-esque, and it was just way over the top because I was there to test in a very standardized fashion, but this is somebody who felt like she had to put on some sort of show. And so you have to be very careful of individuals that are going to be attention-seeking and overly dramatic, because that may end up giving you a false reflection or representation of the severity of the symptoms that they're experiencing. So with borderline and histrionic, you really want to make sure that you are avoiding excessive familiarity. You want to establish those boundaries that you are the health professional and they are the patient. You want to show professional concern, but you really want to stick to the objective stuff and stick to the facts. With narcissistic personality disorder, one of the biggest issues that a physician has to deal with is kind of like the knowledge competition. People that are narcissistic put on an air that they know a lot of things and they should be reinforced for that. So they will oftentimes challenge another individual that they feel is a threat in some way. This particularly comes out when they do feel threatened or insecure. So if they're not feeling well, they're already in a state of insecurity, and it's made worse by interacting with somebody who has a higher potential educational degree than you are. These are patients that don't understand why they can't get an appointment as soon as they call. They don't understand why they have to wait once they arrive to the doctor's office. They have an attitude of entitlement. They oftentimes, during the evaluation process, will almost act as the person's colleague rather than a patient versus doctor. So what's important for the doctor to do is to validate their concerns and to give their symptoms attention, but to also, in a very kind of diplomatic way, make sure that they understand the levels of experience, that I'm the doctor and you're the patient. But if you're really good at your job, you can kind of channel the skills that they're using. Oh, so you researched this. Well, I'm glad you researched that. That really helps me out when it comes to reviewing through the treatment options you have. Taking some of the things that they've already done that's of benefit to the treatment protocol and making it seem like they are a part of the collegial team, when in fact you're just kind of validating their concerns, if that makes sense. So these are the diagnostic criteria, and just like with the cluster A's, I'm not going to go through them specifically. You'll need to go through these when you are generating your own case for assignment number 3, because you'll have to come up with a case that is not one of the cases in the first part of assignment 3. So these are the criteria for antisocial personality disorder, borderline personality disorder, histrionic, and narcissistic. The last cluster that we're going to talk about are the cluster C personality disorders, which are characterized as anxious or fearful. Just like with cluster A, there are only 3 personality disorders in the cluster C: avoidant, dependent, and obsessive compulsive. Avoidant personality disorder is characterized by being socially inhibited, feelings of inadequacy, and hypersensitivity to judgment or criticism. Dependent personality disorder is having an excessive need to be taken care of and a fear of abandonment. And obsessive compulsive personality disorder is very similar to obsessive compulsive disorder. There's a preoccupation with orderliness, perfectionism, and just control overall. This again is a table that was adapted from the Ward article, and again it just discusses the disorders, their prominent features, the experience of illness, problematic behaviors, and management strategies. All of these disorders have the underlying component of anxiety and fear, so all of them are going to require some sort of reassurance when it comes to managing treatment and interacting with these patients. With avoidant personality disorder, one of the biggest problems that you have to be mindful of is, as the name implies, these individuals avoid anything that may make them feel uncomfortable. And one of the things that makes people most uncomfortable is experiencing a symptom that you've never had before and you don't know what the cause is. So these individuals may avoid seeking treatment for fear of being judged or humiliated for the symptom that they're experiencing. And that's even more so an issue if the symptom they're experiencing is embarrassing by nature. So if it relates to gastrointestinal problems, if it's related to reproductive organ issues. So one of the things that may happen should they choose to seek treatment, their symptoms may be fairly severe at that point in time, or the condition may be fairly severe at that time. But even when you're interacting with these individuals, they may withhold very important information for fear that they are going to be criticized or judged. Now, we all kind of do that in some capacity, so that's not necessarily a completely abnormal thing, but they will do it on a consistent basis because they have such a significant fear of being rejected. So you may go to the dentist, and this isn't a personal story by any means, and the dentist may ask you, "Kelly, do you floss your teeth every morning and every evening?" And what do you think that I say? I say, "Yes, I do, doctor, yes, I do." When you know perfectly well, I probably floss when I can remember it. So I'm not just talking about doing something like that. I'm saying that they may withhold pretty critical information that would help come up with the most optimal treatment protocol for them. Another issue too, because they don't want to be scrutinized and judged, they may not ask the doctor for clarification of something. And if the doctor is speaking in med speak or speaking very quickly, they won't ask for clarification because they'll feel like they should already know it. So from a management perspective, it's really important for the doctor to validate their concerns, provide reassurance, and actually encourage them to report any symptoms that they may feel are applicable to their particular condition. Kind of putting the ball in their court and saying, you're the person who knows the best about how you're feeling right now. And so I'm relying on you to tell me the symptoms that you may be experiencing. And even if you think those symptoms may not be relevant, it's important for me to know because I am here to treat you and help you get better. And in that way, you can see that that's very reassuring, but it's also allowing them to know that the knowledge that they have about themselves is important and not anything to be humiliated about. For dependent personality disorder, these are individuals that have an excessive need to be taken care of. Just like there is some relationship between antisocial personality disorder and malingering, there is some relationship between dependent personality disorder and factitious disorder, which used to be referred to as Munchausen syndrome. These individuals have a need to be taken care of. They oftentimes will exhibit submissive behavior for somebody that is a more dominant personality, and they may prolong the symptoms or increase the severity of the symptoms that they are experiencing because of that need to be taken care of. The opinion in their mind, not an opinion so much as a feeling in their mind, is that the longer I am incapacitated, the longer this person will have to stay with me and take care of me. One thing you have to be mindful of as a healthcare professional is you don't want there to be any sort of transference between that attention seeking they have of a loved one or a friend to you as a doctor. So it's important to provide reassurance and to alleviate any anxieties they have about an illness, but you also want to be very realistic in the boundaries that you set for these individuals, because you don't want them to become then overly dependent on you. You're going to want to enlist others, such as a spouse or a family member, to help out with their care, but you want to make every effort to not give off the impression that you're rejecting the patient in any way. Now, in some variations, some extreme variations, a person that is strongly dependent personality disorder may actually do things to themselves to keep them being sick. Or in the case of what was formerly referred to as Munchausen syndrome by proxy, they may hurt a loved one for the sake of getting attention. And I'll talk about that in a few minutes. With obsessive compulsive personality disorder, there's a lot of routine and rigidity in the way that this person behaves. And again, one of the things that makes us feel like we're completely out of control is experiencing a symptom that we've never experienced before, or experiencing an illness that's going on for longer than we expect it to. So these individuals will come to the physician's office being very fearful that they're losing control, and they may come in with documents outlining timelines showing when they've had symptoms, how severe their symptoms are, anything that they feel has triggered their symptoms. You want to try and encourage them to give you that sort of reporting. In that sense, these patients are very helpful because you have a track of what they've experienced and when. But you also want to be careful to not let them overdo it, especially if their rigidity and perfectionistic tendencies are interfering with their medication usage or their adherence to any sort of treatment that you've prescribed to them. You know, if they say, well, I'm supposed to take this medication at this time, but that's not the time that I take medication. I do this at this time. It's really important to emphasize to them why they need to do things at a specific time, and you're just very thorough with your explanations, but you're also providing those explanations in layman's terms. You also want to try and keep things fact-based. Don't emphasize uncertainty, because that may set them over the edge. You want to encourage their routine and their structure into their treatment that you're designing for that particular individual. So just like I've done before, these are the diagnostic criteria for avoidant, dependent, and obsessive compulsive personality disorder. Lastly, we are going to talk about some other considerations, and I'm going to try and not go completely off track here. Admittedly, this is my area of research in graduate school and currently, so I get kind of excited when I talk about some of these other things, but I also have to acknowledge that not all of you are interested in the same things that I'm interested in, so I'll try to keep it condensed as much as I possibly can. In some instances, you have a situation where a person is experiencing a symptom that is atypical from what you would expect given a particular disease or illness, and it's lasting for longer than you think it would be. In that sense, it's possible that the person isn't truly experiencing that condition, but they are exaggerating it in some way. Now, there's a chapter that I need to still copy and upload to Blackboard that offers some case study examples that distinguish between the four conditions, well, really the three conditions that we're going to be talking about: malingering, factitious disorder, and then factitious disorder imposed on another person. This is a table that really helps distinguish something that we talked about in an earlier lecture, somatic symptom-related disorders, with factitious disorder and malingering. One of the biggest differences is in the symptom production. With somatic symptom-related disorders, the symptom production is unconscious. What I mean by that is, for whatever reason, it could be cultural influence, it could be personal bias or opinion, the person doesn't feel that it is acceptable to display psychological symptoms, but it is acceptable to display physical symptoms. So what happens is they may be depressed, they may be anxious. Think about some of the symptoms you experience when you're very nervous about something. Your heart may race, you may sweat, you may shake a little bit, but rather than attributing it to anxiety, what somebody with somatic symptom-related disorders may do is attribute it to something physical, such as a heart condition. We're all prone to doing that when we're little kids, and so I'm providing this example to help kind of illustrate this a little bit more. Think about what a younger sibling, or if you can go back and remember when this happened to you, your first day of school, your first day of formal school, and your mom and dad or your guardian asked you, "How do you feel?" Most young children that are the age of 5 or 6 can't articulate eloquently, "Well, I'm extremely nervous to meet new people and to meet my new teacher. This will be something that I have to transition and adapt to." No, most 5 or 6-year-olds would say, "I don't feel well. I have a tummy ache. My head hurts." Well, that's actually what somatization is. It's taking those psychological symptoms and manifesting them in a way that feels more appropriate to you into some sort of physical manifestation. With factitious disorder and malingering, the symptom production for both of them is conscious. But the reason they are consciously producing those symptoms are for different reasons. For factitious disorder, a subtype of which is Munchausen syndrome, the person is intentionally producing symptoms for the sake of getting attention. In that sense, it's for primary gain or psychological needs. These are individuals that like the attention that they get from doctors, from loved ones, from friends, from the community, and that is why they are sick. So what ends up happening is they will either completely fake their symptoms, or if they are truly experiencing a condition, they will exaggerate the severity and the frequency of those symptoms so as to get more attention. With malingering, the symptom production is also conscious, but the reason why the people produce these conscious symptoms is because of secondary gain. They are exaggerating their symptoms, or they are faking their symptoms because they will get a bigger payout from a personal injury lawsuit. They will be able to get more time off of work from workers' compensation. They will be able to acquire more narcotics or drugs for any sort of pain condition that they may have. They'll be able to get out another tour of duty if they are a veteran. So anything that will give them some sort of secondary gain. Now, one thing that's really important to note, just because this is my area of research, doesn't mean that I feel every patient that comes into a doctor's office is faking in some way. In fact, a majority of patients are not faking their conditions. With malingering in particular, there's been a consistent body of research that has shown that the base rate or prevalence of malingering is around 30%. That means about 30% of the time, when a person is exhibiting symptoms that seem to go beyond what their condition would entail, it's possible that they are exaggerating or intentionally producing them. Even still, even if there is gross evidence that a person is faking or exaggerating their symptoms, it's always important for clinicians to err on the side of not saying anything to them rather than accusing them of doing something that they may not be doing. And there's a whole lot of contextual factors that need to be taken into consideration that go beyond the scope of this particular lecture material, but this is the focus. Being able to figure out how to detect malingerers in various evaluation settings has been the focus of my research. So for anybody that's interested, I would encourage you to contact me for additional readings. With factitious disorder, there are two different types of factitious disorder. There's factitious disorder imposed on self, and there's factitious disorder imposed on another. This is formally known as Munchausen syndrome by proxy. In the first case, these are individuals that will falsify physical or psychological symptoms or exaggerate them for the sake of getting attention. And unfortunately, in some cases, these individuals will do so by intentionally harming themselves. They will inject themselves with things that are toxic to their body. They will consume too much of a medication in order to make them sick. Part of the discussion question that I'm having you guys do for this week is related to finding an instance or an example of factitious disorder imposed on self. There was one I actually just read recently of an individual that was injecting herself with something, and unfortunately she injected herself with too much of it and ended up dying in one of the bathrooms in the hospital that she had presented to. In very rare circumstances, there is something called factitious disorder imposed on another, what we commonly refer to as Munchausen syndrome by proxy. I know this is kind of an old movie beyond some of your time because you're all youngins, but if any of you has seen Sixth Sense, you'll know that there's actually an example of Munchausen syndrome by proxy in that movie. In those particular circumstances, a person, usually the mother or a parent, will intentionally cause their child to be sick for the sake of getting attention for the family. There was a story a couple of years ago that I presented to my class of a mother who would shave her daughter's head because she had told the community that her daughter had leukemia. And one of her teachers, one of the little girl's teachers, noticed that some of her hair was growing back. And the teacher said to this little girl, "Oh, have you stopped your cancer treatment?" And the little girl said, "Oh, my mommy didn't have a chance to shave my head this weekend," which kind of raised a red flag to the teacher's eyes. So she contacted the administration at school, and long story short, it was found out that the mother had been faking the entire condition so that her family could go on a vacation. So the community was raising money for them so they could go off and have fun. So with factitious disorder imposed on another, the perpetrator is the person who's receiving the diagnosis, not the victim. So that is the lecture.